Thank you. We want to talk obviously operational pressures and what we can do and processes, what we can do around that. As I said before, I think this is really about managing. This is about managing risk in the system and making our systems work as efficiently as possible. And it's really complex because you've got often, as I say, tens to hundreds of thousands of patients flowing through a system, and you've got several thousand staff within each hospital, and that is a hugely complex, each with their own different opinions how things should work. Every patient is different with different needs, so actually that's really complex. So actually what we need is some simple rules and simple principles to work off, first of all, for devising the right processes, and then once we've got those processes and agreed them, it's about rolling them out and sustaining them, and keeping that going. And as we know, with high number of people, high number of patients, it's easy for things to sort of change and go off on their own tangents and own track and things. So it's really one of the challenges around this is how we get principles in place, how do we put them in place so staff buy into them. That's part of the thing actually, and actually then how do you make them sustainable and work? There's no point having something that actually isn't sustainable, and that responds to risk. So we can have hospitals running escalation for long periods of time. If you're in escalation, if you don't do anything differently, you won't get a different outcome. So actually, what can we do differently when we're in escalation to take us out of escalation, other than doing the same thing or a little bit faster what we did before? It should be a different thing, and that's the thing about risk as well. Our response to risk, we may do things in escalation we would not normally do, but there should be reasonable adjustments to reduce the risk in another part of the system. And I hope that makes sense in terms of that. First of all, I suppose it's interesting in people's thoughts on what the key principles behind operational processes should be. As a discussion, any thoughts? Ellen?
I think whatever the processes are, they should be simple, because if they're not simple, people won't follow them. So I think that's a good principle to start with. I mean, I'm really interested, Ben, I guess, from your perspective about getting them in place and making them sustainable. And, we've, in this trust, certainly did lots of work around the standards and, people buying into them, but it doesn't last. So we put them in place, we put a lot of oversight into it for a while, and then it just falls by the wayside. And I liked your point earlier about risk as a spectrum. It's not kind of just risk in one area or in another area, or actually, allowing other areas to become more risky because some are more risk averse. And I think, as a big, busy hospital, those are the things that we find really challenging to kind of to drive and be able to deliver. And in fact, we've got a workshop coming up in a couple of weeks, where we've put a lot of new infrastructure in place to help us manage flow in a much better way across our acute receiving areas. But actually, we've spent a lot of money putting a lot of infrastructure in, but what we haven't done is, or what we haven't managed to do, is to change the processes, because people are very wedded to the way in which they work. And I think when you're more under pressure, people are more apt to do that because they try to contain their own area, so they're less willing, I guess, to look outwards. So I think the underlying principle should be the processes should be simple and easily understood and easy to follow. But I think even if they are, it can be overridden by people's propensity to want to continue to do what they've always done, particularly if you're under pressure.
Thank you. Yeah, I mean, change is difficult, and sustaining change is even harder. I think, I suppose one of the things is actually bringing it back to patients. Most people come to the health come actually, what is the patient, relating it back to individual patient. There is a patient currently, Mr. Smith, with a broken hips at the back of an ambulance for 2 hours. He's not getting to ID. There's a patient in RED. There's a patient on this ward, been waiting this long for this, and relating it back to them, making it real for people. And that if your relative was this thing, my relative question is really, imagine that's your relative, right? What are we going to do to try and help them? How can we collectively? And those conversations, and I think with the standards, in terms of professional standards and things, it has to be, they should be raised around patients. What is the best patient pathway? What are the key things? What we want to feel? What is a reasonable thing to do? What are we going to do if it's not happening? So part of the escalation process, of course, is what's your plan if there's not, that can't happen? What's your escalation from that? And everyone's got to own that, I suppose, is one of the key things. Liz has got a hand up.
Yeah, thanks very much, Ben. I hope I'm not going off piste here, but I'm thinking one principle which really links to what Ellen's just said is actually induction for all. You know, one of the reasons why I think we get a lot of slippage is that, quite rightly, there are staff training program turnovers with your junior docs and your more senior docs. Less so with nurses and more losing nurses, hemorrhaging nurses. But then, you know, you can very soon, in 3 to 6 months, have a whole staff group that know very little about all the stuff you spent a lot of time on. So I think one good principle for me would be that hospitals adopt, however brief and however they do it, an induction for all on any of the things that they espouse to be their key principles of working.
No, absolutely agree, Liz. And I think, yeah, in terms of professional standards, every induction, every nurse, every doctor should be handed a copy or email a copy. But it's not as important. It's not just the copy. It's actually telling them why you've got those things in place. There's no point in saying this is the rule. They'll go, yeah, fine. This is the rule, and this is why it matters. And that's the thing. The key thing is that they have to be principle based, and bringing it back to them and their relatives. What would you feel like it was you? And that will. You've got to anchor in people's heads somehow, and also make it accessible, so they're not buried under 17 sub-menus in a thing. If you've got escalation processes, and they have to be accessible quickly on the intranet and that sort of thing. Carla?
Thank you ever so much. Just building on those points that have been raised, and something you referenced as well in your introduction to the session is that trusts are in heightened escalation for long periods of time. And although that as an organisation we do have an escalation framework, we have everything up to a full capacity protocol, the actions that we take under those, as Ellen said, they work for a while and they become the way of managing escalation, but then they do fall by the wayside because they're incredibly resource intensive or they're hard to do, and people quite understandably focus them back in on their own patients, and it's not about taking the next patient from ED into acute medicine, or acute medicine they can't get the next patient onto the ward, so you kind of stop in your own area, and you understand exactly why people do that. And I suppose it's how to keep the momentum on the next patient and not just the patient you got in front of you. To have a bit of a discussion about how to embed those sorts of principles would be really helpful.
Cool. Yeah, I agree. Yeah, and I think it's back to patient and things like when do you want your patient on your ward? Is it 8 at night when actually you're on no ward leader, no medical cover other than the ward medical? Actually, when is it best in the daytime? What's the best thing? Talking about the patient ambulance is your patient, the patient in the admissions ward is your patient. It's that one of the questions you can ask teams and just what people think is, do we as an organisation treat people by location, or do we as an organisation treat people by what is wrong with them? And actually, we of course should treat them by what is wrong with them. Sometimes we end up back in that treat by location. So they're not in my ward, I can't see them, and I don't see them in ED, I don't see them. Actually, if you start to have that principle, you can start to move mindsets and things, and it's that test. Any further thoughts on processes and escalation? Helen?
It's not thoughts on process and escalation, but it's just about what Carla was referring to is the constant state of escalation. And a lot of organisations haven't really perfected de-escalation, and de-escalation is actually more important often than the escalation status. So, you know, even if it's only for 3/4 of your day, you're in a de-escalated state, it gives everybody that little breather. It's too easy sometimes to just remain on high, extremists and a high state of escalation, rather than actually really taking a good look and can we de-escalate at this point in time and get that message out there so we have de-escalated, so that it doesn't become the new norm, which it is the new norm at the moment. Carlo, I absolutely agree, to be on that heightened state of escalation on a permanent basis. Absolutely.
Alison?
Yeah, and I think, leading on from that, I think that's a really, really good point. And, as you say, it's bringing all that resource in. It's very intensive. And then we go back to, and it's asking yourself, what are you going back to? And what's been learned from that period of escalation to avoid going in? What is it we can do to avoid going back into that again? Because if we go back to and end up going back into escalation, you're just fulfilling that prophecy again, aren't you, of going back to the norm. We need to change the norm to avoid going into escalation, and it's identifying, one or two things that will sort of
stop that or to take away from that escalation that you can do as every day. And I think because it's either all or nothing, isn't it? It's all escalation, everybody's running around, then very, very brief sort of, as you say, de-escalation. It's not a lot because we've normalized escalation now. So in a way, a lot of things fall away that we should be doing rather than having it as business as usual. Does that make sense?
Absolutely. Andy?
Yeah, I agree with everything that's been said. I think just to add on to some of the conversation that's been said, for me, it's about if you've got action cards at various OPAL levels for different departments within the hospital, which you know, most hospitals have got these action cards, it's really important that they're co-designed with the departments, and the departments come up with their own actions. Because and it links into Ben's point really, in as much as we have to do something differently. We don't have to do what we do currently just a little bit faster because we get exhausted doing that. So it's about going to, and I'll just take as an example, it's about going to the medical division triumvirate and saying, we want you to come up with a set of actions at each OPAL level. So at OPAL level 4, we know our patients are at risk. We know that, you know, it's well documented. What can you do that's extraordinary and different that will, you know, you're going to do something very different at this point. But if they're implemented and kind of given to the divisions and departments, they're much less likely to engage with them than they are if they develop them themselves. So I think it's about co-designing those action cards with the departments, because if they're not de-escalating at OPAL level 4, then the actions really aren't fit for purpose, because that's the only purpose of those actions, is to de-escalate the hospital. So it's about then going back to the division and saying, okay, great that you've come up with this. Now we need to look again, what else can we do, because we're still not de-escalating. For me, and I've made that sound very simple in a few sentences. I'm not suggesting for 1 second that's easy, but I think that's kind of the way forward from my perspective.
Thanks, Andy. And I think some of this stuff when we do it is really important to clarifying the goal of what they're trying to do. What's the goal of the action? Sometimes we have an action that just says you will go and do this. A good example would be we're going to go and do daily consultant review, and if it, everyone would because we're stuck in the system, and if a consultant goes hello to 24 patients, nothing has changed, nothing has been achieved. So actually, what was the purpose of that? Why are we asking people to do things? You're asking people, and sometimes we can be guilty of going, we're going to go and do this, and actually what will it achieve? What's the output we're looking for? So a good example, we want more people in the discharge lounge. Well, we don't really want more people in the discharge lounge. We want more people from the admissions units going to their base wards earlier in the day. That could be the discharge lounge, it could be early discharge, it could be sitting people out, it could be sending them home and taxing their blood medications to them, it could be making sure the relatives pick them up earlier in the day. Doesn't matter what the thing you do does, the point will be is, have you managed to fill your bed earlier? And that's it. And we get caught up in discharge lounge use when actually sometimes the discharge lounge, full or empty, if everyone moves to the ward by midday from the admissions units, doesn't matter how they do it, as long as it's a reasonable way of doing it. So what is the goal here? And actually explaining why is really important. Andy? Yeah,
I absolutely agree with you, Ben. It was just a point, Ben. I'm just thinking time really. We need to do the Menti as well. Is now a good time to move to the Menti, do you think?
Yeah, absolutely. Yeah. So I'm going to hand over to Stefan and Andy to do Menti, which is really just a questionnaire online about your thoughts on some of these things. So I'll let my expert IT literate colleagues do this for me.
That's Stefan, not me, I would say.
He's got his concentrating face on.
He has, hasn't he? Yes.
Right. I guess, can you see the screen if I do the IT and then you lead it, Andy?
We can see that, Stefan. Yeah, you just need to present now, mate.
Yeah, it's just doing it now.
So what we've got is a Menti session, and the other groups will be doing something very similar to this Menti session. What we've got is a Menti session. I'm not going to explain Menti too much unless anybody wants to put their hand up. I think most people have, utilised Menti. What you can do is, if you can either join through the website there with the code, or much easier if you use your mobile, just to go on the QR code with your camera and log in. I'll just give you a few seconds to do that.
Just to say, Andy, I can't see the screen other than what's on the presentation. So if people have got any comments in the chat box or hands up, I won't be able to see that.
Okay, mate, I got it. So just stick with that screen for a second, Stefan, until people have just logged on to the Menti session. Okay, if you go to the next, has everybody got that? Has anybody not got that? Shout now. No. Okay, lovely. So this slide here is referring to the conversation we've just had, really. So there's a set of objectives here, 3 objectives, which Ben touched on in his presentation. So optimise patient pathways and balancing risk, implement sustainable changes using a quality improvement approach, and showcase good practice, including things like, this isn't an exhaustive list, but things like the focused model, internal professional standards, criteria discharge, those type of things, really. But they're examples rather than an exhaustive list. So they're kind of the key objectives that lead the next session, if you like, and a number of questions that we're going to put up. And what we'd ask for is your input into each of these questions. So if we take it to the next slide, Stefan, just a slide, just where are you? So if you on your mobiles just log on to that next screen, it should give you a little dot and you can put where you are somewhere on the map, hopefully. I'm taking that's Chris Morrow Frost. How did I know? Just a bit of an exercise to get us using the Menti. Has everybody had an opportunity to do that? I guess there's no more coming, so yeah. So what we'll do now, Stefan, is take it to the next slide, if that's all. That's okay. So now we're really looking for your inputs here now, I guess. So what elements of your operational processes are you most proud of? I'm thinking, obviously, this group is about ops, so it's specifically operational processes. Which elements are you most proud of? So just give you a few minutes to just kind of start and put some responses into that. Direct to speciality admission processes, right team, first time. Absolutely, absolutely.
There must be more pride out there than just that.
Yeah, I was just thinking, have you got good SDEX or yeah.
Now we're up and running. So good. Simple, inclusive, well communicated, held to account, excellent leadership. Really important. And I think it touches on that specific point, touches on some of the stuff earlier. How do we make some of this stick and how do we make it sustainable? You know, and that clicks into quite a few of those, really. You know, keep it simple, keep it inclusive, well communicated, held to account is really important. It makes it sound a bit kind of performance management-y, but it doesn't need to be, does it? But actually, some things can't be optional in an organisation. If we decide as an organisation we're going to do something, actually we're doing it. You know, it's just about having rules, I guess. Multi-professional discharge processes, excellent. Medical and nursing seem to support and be signed to Q. Leadership in patient discharge, yeah, absolutely. Operational huddle to debrief following the weekend period. I think that's critical, and that kind of operational huddle and debrief is a part. I don't know if people know about the focused model that we've been developing in ESIST, but it's a significant part of it, really, about ensuring you have debriefs as part of your processes when you're in high escalation, to understand what it is we should be doing differently. That links into my comment earlier, I guess. Why are they coming thick and fast now?
Apologies, I can't control the speed of the scroll. It's just an automatic function.
Okay.
And there's been some changes. I think the one about the signed to the coup means it's changed there to aligned to the coup. So I think there's a few little resubmissions with some typos you can see back there.
Okay.
No blame, robust, rigorous site meetings, no blame, action focus and good information data. That's really, really good, because I think we've all been in very uncomfortable site meetings in our years.
Speed of communications absolutely critical. You know, we've got things like WhatsApp nowadays, which certainly makes life a lot easier.
Okay.
I think
don't think that's is that scrolling the same messages now, Stefan?
I think we are the same ones, yeah.
Okay, so that's great. That's really good. What we'll do now then, if we've exhausted that slide, is we'll move to the next slide, Stefan. Okay, so if on your mobiles you can, I think you have to move it yourselves onto the next one. So what do you see as the barriers to supporting and improving operational processes?
got our first comment, poor leadership.
Yeah,
workforce turnover, very definitely. You know, and included in that, certainly my background's nursing, I would include the fact that we employ significant amounts of agency nurses, some of whom are very good, but they're transient and they're not on the same ward all the time.
And that goes back to the sustainability, doesn't it, as well, that we talked about earlier, about, you know, putting in new infrastructure and processes, and it doesn't sustain, but that would also directly link to the workforce turnover and that suggestion of having the induction for everybody who starts.
Yeah, absolutely.
Is there also something about rotas in that as well, in workforce turnover? So when you come across junior doctors as an example, in a recent organisation that I've been in, there was one junior doctor who was on 3 different wards in 3 different days. So the continuity of care for patients and their understanding of patients was a real challenge.
So can I just say I totally agree with that last comment. I put workforce turnover, and I also very definitely mean what you've just conveyed. We get docs who are placed through a rota, a band 4 non-clinical person does the rota and puts them in different areas on different days of the week. So even if they're on duty all week, they may not get to see the patients that are in all week that they started off admitting. So there's absolutely no continuity of care, and that's just horrific.
Yeah, and certainly what we had the junior doctors describe, you know, it was a very frustrating process for them. Because they didn't feel like they could really maximise their input for their patients, because they were having to get to know a brand new bunch of patients each day, and it didn't seem for them to be aligned to any workforce strategy. It was, like you say, it was just somebody who was non-clinical, just putting their name in an empty box, if you like, to fill a space rather than thinking about the process.
Chris, I'm just picking up on your comment, Chris. Are you only able to put one comment? Does it only allow you to put one comment in? Does it? If anybody's got anything else they want to put in the chat box, we'll capture it that way. If anybody's got any other points, sorry about that. I'm not sure.
I was going to say about culture and behaviour came up twice, and absolutely. So I put it in the chat. Actually, there's an equation which is culture is behaviour times frequency. We often say our organisational culture is this, and it's a lovely aspirant thing. But the culture of any organisation is actually the behaviours we display as an organisation, how frequently we do them, in many ways, and actually, and that's one of the hardest things to shift, isn't it? To change the culture of an organisation or a department, whoever, is hard, but it can be done. And actually, it's how we do that, and how we do it. And I think that's where the principles of relating things back to patients and making it real for people is by far the biggest motivator for people.
Yeah, absolutely. I think I'm just looking at the time. We've got 3 minutes to go. I think we've got one more question, have we, Stefan?
Yeah, I'll move us on.
Should we move to that then? Okay. So we've got some answers already.
Somebody's beat us to it.
Absolutely. So what support would be most helpful? When we've got already started for 2. So poor communication, speed of change. I wonder if the poor communication was on this last slide, Stefan. what support would be most helpful.
Apologies.
So it seems there's only one answer allowed again. If you've got more than one answer, please do feel free to use the chat box to put any ideas in there.
Would it be helpful to talk about sustainable stuff as well, as you said at the start? We know putting processes in you can't sustain or do, and that's one of the key things with this. It's the how do we make things that we do, one, effective, and two, sustainable. If they're neither of those two things, then there's probably little point in doing them.
I absolutely agree, Ben, and some of that links into some of the stuff we've already talked about, doesn't it? You know, if there's an optionality to do things, then you know it drifts. That's where you get drift. You know.
Got another comment come in.
Time is important, yeah.
And I guess really the question of this is what support would be most helpful. Is that in, you know, in how we would support you or supporting with something? So how would support would on clinicians on site supporting some of the operational processes, supporting some of the decision making, something like, or is it more, you know, you would like a workshop, or is that the sort of question you're looking for with this?
Yeah, I think so. Huh? Yeah.
One of the things we could offer is things like support to facilitate discussions sometimes, because some of these discussions can be tricky. Things like internal professional standards, things like ops policies, and things actually can be tricky. I actually want to how to facilitate a discussion. Without example, one of the things we can do. I think part of the group we'd love you guys to share ideas, because you'll all have great things that work really well, and sharing those ideas is really important too.
I think that's the last slide, is it, Andy?
I think so. Mate.
I'll just check.
Okay.
Yeah.
Yeah.
Okay, I'll stop sharing my screen now.
I think we're being summoned. The main room link.
Yeah, I think so. Crystal's helpfully put a link back to the main room. So I guess that's us done, guys. We're going back to the main room now. So thanks very much for your input with this session, and we'll see you back in the main room.
Thank you.